Welcome back, everyone, to part 116 of our masterclass. I am your lead instructor, Harshal, and today we are diving deep into advanced surgical DRG assignment. Specifically, we're taking a really close look at Major Diagnostic Category 21 that covers surgical procedures for trauma, injuries, and poisonings. Now, you might remember in part 115, we tackled the medical side of MDC 21, but today is all about the surgical drivers that completely flip the reimbursement landscape. Let's jump right in.
Real quick before we get into the heavy lifting, if you're enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. It really does help keep this masterclass going strong.
All right, here is our roadmap for today. First, MS-DRG architecture and partitioning. Second, mastering PCS root operations. Third, high-yield CC and MCC capture. And finally, Number 4, CDI and audit defense.
Okay, kicking things off with Section 1, MS-DRG architecture and partitioning, focusing on the surgical override.
Think about how massive the MS-DRG system actually is for a second. It's kind of mind-blowing. It takes literally thousands upon thousands of possible diagnosis and procedure combinations, and then neatly funnels them down into roughly 750 distinct payment categories. And the whole point of this giant puzzle? Grouping cases by clinical and resource similarity.
So how do we actually land on that final DRG? Well, for MDC 21, it boils down to this three-step surgical partitioning logic. Step 1 is straightforward. Your principal diagnosis sets your major diagnostic category. But here is the absolute game changer for trauma and injury cases. If the patient has a significant operating room procedure, say an OR wound debridement for a bad traumatic injury, or maybe the surgical extraction of a deep foreign body, that procedure acts as a trump card. It completely overrides the medical trauma diagnosis and partitions the whole case into a much higher-weighted surgical DRG.
Moving right along to Section 2, Mastering PCS Root Operations. Precision is everything here, folks.
In the surgical and trauma world, you absolutely must know the difference between excision and extraction. Excision, which will code with the letter B in the third character of your PCS code, means explicitly cutting out or off a portion of a body part without replacement. Picture an excisional debridement, where they are cutting away devitalized tissue with a sharp instrument, right down to the fascia or muscle. Extraction, on the flip side, means pulling or stripping out tissue by force. We're talking non-excisional scraping or something like vein stripping. Getting these two mixed up? Yeah, that is a massive compliance risk.
To put that into perspective, let's look at the mechanism of a percutaneous liver biopsy. If the surgeon goes in and performs a fine needle aspiration biopsy, you code that as an extraction. Why? Because you're literally pulling fluid and tissue out by force. But say they use a larger bore core needle instead. That needle actually cuts a physical core of tissue out of the liver. Because of that specific cutting action, a core needle biopsy goes straight to excision. See? It's all about the mechanical action of the procedure itself.
Let's break down a few more of these highly confused root operations. We already know excision is taking out just a portion of a body part, but resection, that means cutting out the entire body part, like a total mastectomy or a total nephrectomy. And then we have destruction. Destruction is exactly what it sounds like. Physically eradicating or obliterating the tissue. Think of cauterizing a skin lesion. In destruction, you aren't physically taking any part of the body out and putting it in a jar, you are just destroying it right there on site.
All right, on to Section 3, capturing high-yield secondary diagnoses, meaning our CCs and MCCs.
Now, a comorbidity isn't just some random bullet point sitting in the patient's past medical history. No way. To compliantly capture these conditions as secondary diagnoses, they have to be actively clinically evaluated, therapeutically treated, require diagnostic procedures, extend the length of the stay, or demand increased nursing care and monitoring. They have to actually impact the current admission.
Documenting high-yield MCCs, those major complications and comorbidities, is exactly how we show the true, real-world severity of a trauma patient's illness. When you document conditions like acute respiratory failure or severe sepsis secondary to an infected traumatic wound, you are drastically increasing the resource weight of that case. Just keep a close eye on your POA indicator, right? If a secondary diagnosis like sepsis wasn't present on admission, it might impact how that weight is calculated depending on the specific grouping logic you're working with.
And finally, Section 4, CDI and payer audit defense.
Listen, overly aggressive coding without the explicit documentation to back it up,
it is a total disaster waiting to happen. It's going to trigger compliance audits and completely wreck your taste mix index. For instance, if a provider casually writes chest pain in a discharge summary without linking it to an established acuity level, like saying it's an acute MI, that creates a severe revenue loss and a massive compliance headache. Simply put, we literally cannot code what isn't explicitly documented.
And this is exactly where experienced coders earn their keep, by protecting the hospital. They do this by raising structured CDI queries. Say you are looking at what appears to be an excisional debridement, but you read the operative note, and it doesn't mention the specific tissue layer reached, or it doesn't say a sharp instrument was used. You stop right there. You identify that missing specificity, you raise a formal query to the clinician, you track it until it's closed, and only then do you code it definitively. That is exactly how you build an ironclad defense against commercial payers who try to downgrade your excisional debridements to basic, non-excisional cleansing.
As we wrap up today's deep dive into MDC-21 surgical grouping and root operations, I want to remind you one more time. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.
We covered some serious ground today, from the macro MSDRG architecture all the way down to the micro-level differences between excisional and extraction root operations. But it definitely leaves us with a big question for next time. How do experimental procedures, sneaky payer-specific bundling rules, and tricky modifier issues completely derail a perfectly clean claim? We are going to tackle exactly how to prevent those catastrophic denials in Part 117, where we'll dive into Major Diagnostic Category 22, which covers burns. Keep studying, stay precise out there, and I will see you in the next lesson.